So, good morning, everyone. I would just like to, at the risk of sounding particularly contrarian and nerdy, I'd just like to make the point that I'm not convinced that the gumball machine is truly representative of a random process. No matter how many of my quarters that my 4- and 6-year-olds take and put in that machine, they never, ever, ever get the color that they want. Okay, so on a slightly more serious note, it's really a privilege to be here today to present on behalf of a wonderful team at the University of Pennsylvania that includes Laura Dember, who is the principal investigator of the TIME trial, which I'll describe momentarily, and Susan Ellenberg, who you heard from yesterday, and Steve Jaffe and Jason Karlowicz, two members of our bioethics faculty. So in terms of disclosures, none of us have financial conflicts of interest to report, but Laura is the principal investigator, as I mentioned, of the TIME trial, and I've been principal investigator. I'm currently principal investigator of several pragmatic trials. So there may be some intellectual conflicts that you might consider. So the TIME trial, and the context for this ethics supplement, goes as follows. 400 dialysis clinics across the country are being randomly assigned to either usual care or an intervention. The intervention is an intervention where physicians, nephrologists are nudged or encouraged to prescribe an individual dialysis duration of at least 4¼ hours. Patients receive this 3 times a week. In usual care, by contrast, nephrologists do what they regularly do, which is they pick a number. There is observational evidence that longer dialysis durations yield better survival, but there's been no experimental evidence to confirm this. And there's a lot of uncertainty in the community accounting for the fact that standard of care in dialysis may have incident dialysis patients receiving anywhere from about 2½ hours to well upwards of 5 hours of dialysis time 3 times a week. So those facilities enroll their patients. The patients are notified that they can opt out. They can be given a phone number to call if they don't wish to participate. And then patients are followed longitudinally, with the primary outcome being all-cause mortality and the secondary outcomes listed here. And it's important to think about the context in which this study in particular is occurring. So dialysis care is already a highly protocolized care paradigm. There are really just 2 major players, 2 private providers of dialysis in the country that account for the provision of care to more than 90% of patients who require dialysis. They provide a highly centralized infrastructure. There's only one payer, Medicare, for patients with dialysis, unlike in most other disease states. And increasingly, almost every other aspect of dialysis care is protocolized at the level of the individual dialysis facility. So this is a context in which both patients and providers are highly familiar with the realities and perceptions of what protocolized care feels like. So the aims of the ethics supplement were as follows. So in the context of pragmatic trials evaluating interventions within the standard of care, we seek to understand how patients and nephrologists value treatment autonomy, the ability to make an individualized choice for an individual patient. Second, and importantly, how these valuations differ in the context of research and in the context of clinical care that is also being protocolized. And third, whether these limitations on treatment autonomy should influence, in patients' and providers' views, how investigators obtain informed consent or notify research participants. So we take a mixed methods approach. The first phase of the research is a qualitative phase using semi-structured interviews among patients receiving dialysis at 14 dialysis facilities in the greater Philadelphia area, and then among nephrologists who are members of the American Society of Nephrology, which virtually all nephrologists are. We use the data that we derive from this qualitative work to then inform what will be a quantitative study that we've actually just launched, and I'll mention only briefly at the close of my remarks, which uses an online survey, or actually really a web-based survey, to basically manipulate different characteristics of the trials or the clinical care paradigm that have been found to be salient to people in the qualitative phase, and then look at how people react to those. So phase one, the semi-structured interviews, we purposefully sample patients and nephrologists to promote a diverse range of views. So this is not a representative sample per se. We're specifically seeking to identify very different types of patients and nephrologists so as to get the full range of viewpoints on these issues. We asked participants to reflect on two different hypothetical scenarios, both of which have some similarities to the time trial. One is a research scenario, and the other is a clinical care scenario, and I'll describe these momentarily. The interviews are audio taped and transcribed, and we use constant comparative methods to thematically code what people say in the transcripts. So it turns out that we reached what we call thematic saturation, which means that after three interviews, in three successive interviews, we were not learning anything new. No new themes were identified. And that was achieved after 32 patients and 24 nephrologists. So here are the hypothetical scenarios that we used, just in short presentation format. So the RCT was basically like the time trial. Dialysis facilities are randomized to usual care or an intervention as listed here, and patients are provided with notification and given a number to call to opt out. The clinical scenario that we describe is that a new clinical practice guideline is being implemented in the dialysis facility where you receive your care, or if in the case of a nephrologist, where you work. And the treatment length will be 4.5 hours across the board, and that the goal of this clinical guideline is the intent to improve the quality of care that's being provided to all patients. So we then used a variety of neutral, open-ended questions to guide people to think about the things that we were particularly interested in. These are just a small sample, actually about half of the questions that we used de facto. Most of our questions wind up being in response to things that people say to probe those issues more deeply. But here are some of the backup questions. What are your thoughts and reactions to the research study or the clinical practice scenario that I just described? Can you tell me any reasons that you might not want to participate? How would this, either clinical care scenario or study impact you as a patient or as a physician? And are there other things that you might want to know? So these are profiles of our respondents. The patients were about 50% men, mostly African American, not highly educated overall. About a third had been on dialysis for at least 5 years, and as is true of the end-stage renal disease population, the majority had been hospitalized in the prior year. Nephrologists were predominantly males, which is also sort of reflective of the underlying population of nephrologists. Half were in academic practice, half were in community-based practices, and a little more than half had been out of their fellowship for at least 5 years. So these are the major themes that had emerged. So among nephrologists and patients, some themes that were common to both groups were thoughts about the level or the detailed nature of information exchange between patients and physicians, their thoughts on the opt-out mechanism of consent, the nature of protocolized care and what that means for them, the value of conducting research, beliefs about the evidence behind the intervention and whether it's sort of appropriate to adopt it as a clinical practice paradigm and or appropriate to test it in a research setting. And then the acceptability of the increased dialysis duration to patients. This requires, they are already leading a lifestyle where they're coming into a dialysis facility 3 times a week, and some were concerned that being hooked up to a machine for a little bit longer than they otherwise might be on average is something to be concerned about. Nephrologists had some additional themes that were unique to them, including their own beliefs about what patients would feel about this increased dialysis duration and how the intervention might impact them as individual physicians. And then patients had a couple additional beliefs as well, including their thoughts about the virtues of shared decision-making and their trust in physicians in the healthcare system. So this is what I think is sort of the essence of our work to date, and I'll try and walk you through this slide in a bit of detail. So what we did is had 2 independent coders who are trained in qualitative research go through each of the 56 transcripts and code each as being generally favorable or generally negative or having mixed responses about each scenario, the clinical care scenario and the research scenario. And the data I'm presenting here are divided first by patients and by nephrologists, and then secondly, the research scenario and the clinical scenario within each group. Recall that the order of presentation of the clinical scenario versus the research scenario was randomly decided for each respondent. Now, if views were uniformly positive, they were coded in green as a favorable response. If they were uniformly negative, they were coded in red. And if they were mixed, there were some things that were positive, some things that were negative, they're coded in yellow as a mixed response. And what you can see here is that among both patients and providers, larger proportions of people preferred or had favorable views of the research scenario than the clinical care scenario. Keeping in mind that this clinical care scenario is exactly what's happening in regular clinical practice. So 44% had favorable views among patients for the research scenario versus 19%, and the corresponding percentages for providers were 58% versus 33%. So here's some illustrative quotes that were provided on some of the central themes that we identified. So these are all quotes from the research scenarios. So one patient said, or in this case, using a set length of the dialysis sessions, doesn't matter to me. I don't have a problem with that. I don't really think any doctor should have a problem with it either, really. It doesn't affect them at all. And then a different patient said the following. There again, and this was a patient who had been assigned to the clinical care scenario first and had expressed some objections to the protocolized nature of the clinical care scenario. This patient is saying, there again, I don't think it should be generalized. It should be per the patient. That's why the doctor's better for that. Regarding information exchange, here are a couple illustrative quotes. So one nephrologist said, I think that notifying patients, and as long as the doctor's convinced it's the right thing to do for the patients, I don't see any ethical dilemma with telling them that you need 4.5 hours and giving them notice and the ability to sort of not do it, which they have for any treatment we offer. Every patient has a right to deny. And then a patient said, you know, I have a problem with being put in something and I'm not aware of it. You know what I mean, just putting me in it and I didn't know I was in it and I would feel like that they wasn't being real with me. But putting me in and I'm aware of it, yes, I have no problem with it. I've got to know that I'm being researched or something. And about research value, one nephrologist commented, I think we would definitely want to contribute to that body of literature and then also help to affirm our clinical suspicion and judgment that we've been doing, or I think meaning what we've been doing all along. And then a patient commented, I'd want to know how this research is going to affect me, good or bad. If it's good, I want to go with it. If it's bad, I might have some reservations about it. But it all depends on if I have to suffer to make someone else's life better, then maybe I might consider it. So these findings are leading us and guiding our quantitative research that is now ongoing. And the design here is to use online surveys to both patients and providers, presenting multiple hypothetical randomized trials. So the way these randomized trials differ is that we randomly assign for each scenario different levels of 3 different attributes. And the 3 attributes that we've chosen based on the qualitative work are the level of restrictions on individualized treatment decision-making, or what we call autonomy, the burdens to participants in participating in the research, and the approach that's used to either informing people that the research is ongoing, obtaining consent, or perhaps not informing them about the research. And in each case, we measure the outcome variable is people's willingness to participate in the trial among patients, and correspondingly nephrologists' willingness to enroll their patients in such a trial. And we use a method called conjoint analysis, which derives from marketing research, which has a very nice virtue to it. What it does is, by assessing the extent to which people's responses, their willingness to participate, vary across different trials in which these 3 attributes have been randomly manipulated, it allows us to actually glean people's revealed valuations of these 3 attributes, which is in contradistinction, for example, to a simple survey that might just say, you know, how do you feel about autonomy? How do you feel about burden? Right? So this really provides a quantitative way of people's true underlying valuations of these attributes. So these are our next steps to finalize the coding of data emerging from the qualitative interviews, to quantify the relative importance of those attributes using our conjoint analysis paradigm, and to explore the generalizability of these findings to other clinical cohorts, particularly those in which underlying care may not be as protocolized as it is in the dialysis setting. So to wrap up, I would say that available data suggests that patients and providers are as willing to relinquish autonomy in the context of research as in clinical care, and perhaps more so. And for the several patients for whom they were more willing, and providers for that matter, who were more willing to relinquish autonomy in the case of research, the underlying reason that was expressed for being more willing to abrogate autonomy in that context was their altruistic motives. They understood that there was some greater good that would come of the research scenario and didn't have similar beliefs about the underlying clinical paradigm. Second, almost no one voiced concerns regarding the privacy of their data that would be collected or the risks of the treatment. And this is important because it's not like these were disengaged respondents. They did voice concerns, but when those concerns arose, they focused on other things. They focused on information exchange, less individualization of care, and unwillingness to spend more time hooked up to the machine. And then finally, I just want to reiterate that these findings are preliminary and do require further exploration in future studies. Thanks very much.